This conference makes me tweet too much. It's my favorite. We need to be in the global space to save ourselves, referring to Joe Kohler's presentation. And this tweet just in, if you're going to break your leg, make sure you're passed out, from Dave's session, which is terrific advice on so many levels. Our next presenters represent an organization that, along with Mayo Clinic, is one of the most influential players in the healthcare space. I speak, of course, of Continuum, and here to talk about service design and transformation of the patient experience from the perspective of Continuum are two presenters from Continuum. Please welcome Gianna Marzilli Ericson, who's Senior Strategist for Service Design at Continuum, and Augusta Meill, who's a Senior Vice President at Continuum.
Okay, thanks, John. My name is Gianna Ericson. I am from Continuum. We're based out in Boston, Massachusetts. This is my colleague, Augusta Meill. And it's been really amazing to be here these last few days. We're excited to continue the conversation. And we want to share some thinking with you about patients and consumers. And we're going to offer a little bit of a counterpoint to some of the things that have been said earlier. And you guys can decide how complementary or how contradictory you think we're being. We want to see you all in the back afterwards asking us about it. Okay, so to start off, I want to introduce you to someone. Now, you may have already met this person, but bear with me here. I want you guys to meet the patient, healthcare's newest superhero. Now, in our work at Continuum, it's our job basically every day to design human-centered healthcare products and services. And in doing this work, we've been noticing some things about the role of the patient in these types of projects. And as we, and by we, I'm talking about designers, become more and more involved in healthcare and more focused on the patient, we are borrowing a lot from our experience in consumer design, consumer-centered design. And we're thinking more and more about the patient, in fact, as a consumer, as we've heard many others point out. Now, let's step back for a second and consider broadly what we think about when we think about consumers and what we expect from consumers today. What we found is that consumers are basically expected to parse a lot of information, to proactively take responsibility, and to proactively take control. So we've got increased responsibility, more information, and more control. And what we've noticed along those lines is an assumption that applying this reasoning to patients makes, in turn, for better healthcare experiences. But we actually want to ask the question, is that true? And why is this even happening? So at first glance, it makes a ton of sense, right? It mirrors a more general cultural trend. So right now, in the culture at large, we're all about the democratization of information. We're all about the engaged consumer. And almost everyone has, if they want it, access to pretty limitless amounts of information. Essentially, everyone can be an expert if they so desire. If we think about something as simple as Amazon or Yelp or anything similar, anyone, whether they know a little bit or a lot about something, can review a product or a service, put that review up there, and it'll be placed basically among equal legitimacy among thousands of others. And you and I can all go and read them, and we can see what we think, and we can have as much access as we want. Essentially, today's consumers are content creators. Based on a lot of other talks that we've heard over the past few days, I think we aren't the only ones who've noticed this trend. And of course, we see it in healthcare as well. So our clients, ranging from retail healthcare to pharmacy to insurers, are increasingly focused on understanding and designing for patients as consumers. We see the healthcare system putting greater and greater focus on patients as a nexus for change. And so we see healthcare players adopting the language and practices of consumer centricity, in part because of the realization that influencing consumer behavior can help in a lot of ways, right? It can help drive costs down, it can help grow business, and it can help improve population health. But as a result, we see that patients are having more and more information thrown at them. They're being asked to take more and more control, and they're being asked to take on more responsibility than they ever have before. They're expected to be empowered, They're expected to advocate for themselves, for their loved ones, and they're expected to understand their condition and the system in ways that they didn't used to. So at this point, you're probably wondering, what could possibly be wrong with all of this? And at first blush, it does sound pretty awesome, right? How could we not be all for consumer-centered thinking and design? After all, that's what we do every day. It's part of our mission. Well, we started to notice places where our best consumer-centric instincts actually conflicted with what we saw happening with reality, and where noble practices like providing patients with more transparent information and empowering them with responsibility just weren't, frankly, working. And the sort of concepts that had proven themselves to be really great allies when we're thinking about consumer experience design were falling a bit short in healthcare. We want to share a couple of examples where this type of approach has gone wrong, where treating patients as consumers hasn't resulted in the best outcomes. So the first example I want to share is about clinical report cards, and it's really about access to information. In the consumer world, we often see information as a cornerstone of a really well-designed experience, right? Key information is directed at consumers at the right time with the assumption that they'll then use that information to make better choices. And this example highlights some of the challenges with that approach. It comes from the Journal of the American Medical Association, and it's about clinical report cards, which are basically ways of grading practitioners and clinics on the quality of their patient outcomes. Now, the hope in this case study, which took place in a series of cardiology clinics in upstate New York, was that by targeting this report card information directly towards patients, that they would use it to make more informed decisions about who to see for surgery, which clinics to visit, and so on and so forth. Essentially, the hope was that they would improve their own outcomes by using this information. However, in spite of the fact that they were indeed aware of it, so they knew about these report cards, they had accessed the information, they were aware of it, they pretty much ignored it. So what we saw instead was that they fell back on heuristics from recommendations from their PCPs to just the inertia of having already an established care team, anything from that to being constrained by the system that they were in. So not being able to switch providers, for example, because their insurer wouldn't cover it, and so on and so forth. Essentially, targeting the information at them didn't cause them to change their behavior. But it did change the behavior of another group of stakeholders. In fact, when that same clinical report card information was taken and targeted instead at clinicians and the clinics and the people who were actually practicing care, patient outcomes improved phenomenally. And the reason why we believe this is true is that clinics and the practitioners had the expertise and the influence necessary to interpret the information, right? So they were able to use it more effectively, to oversee and frankly police each other, and therefore encourage and incentivize improvement.
The next example we're going to look at has to do with responsibility and where it's placed in the system. And we're living in a world today where consumers are taking more and more control over their product and their service experiences. You can think of anything from design your own sneakers or your own mini convertible to on-demand services like Zipcar or Netflix. And yet, when we look at this same set of responsibility and control in the healthcare space, we started to see it fall apart. So Atul Gawande has written about a clinic in New Jersey at which doctors, nurses, and health coaches are working together to drive healthcare costs down and to improve care for the most needy, most expensive patients in the community. And through the course of the work, one of the things that they identified as a major driver of non-emergency 911 calls was the simple fact that patients didn't have the 24-hour clinic hotline right at hand when they needed it. So health coaches, in their next meetings with their patients, asked them to please program it into their cell phone, speed dial, and use that number instead. And they waited, and they saw no change. But they didn't give up. What they did instead was literally take their patients' phones in hands. They programmed the number for them. They showed them how to use it. And they watched call volumes drop. And this is a really, really small point in a great article, which I'd encourage you to read. But for us, it was meaningful because it started to identify this conflict between wanting to give patients responsibility and yet watching that fall short. So in examples like these and a bunch of others, got us thinking and got us wondering, what can we learn from this?
Okay, so what we've realized over the course of thinking about this problem is that we don't think that treating patients like consumers is really the answer. And we have a few reasons for this. So when we train ourselves to think about groups of people through a certain lens, what happens is we start to make assumptions about how we should then treat them. And if that lens isn't appropriate, we might make some assumptions that aren't that helpful. And so if we want to improve healthcare experience, we need to think about what being patient-centric really means in a design context. And we need to ask ourselves whether calling it a consumer-based approach always makes sense, because we think that patients and consumers are actually pretty different from each other. Now, don't get me wrong, I'm not saying don't pay attention to patients, because of course we want to pay attention to patients. What I'm saying is we need to pay attention to them a little bit differently than we have been. And we think there's a few key reasons why. So the first is that they don't want to be there. I want you all to think about this for a second, and think about the situation that you or anyone you know or people in general are in when you're in a medical situation. The whole reason why people generally seek medical care is that something has gone wrong, and what everyone would really like to do is just get back to normal. So time and again, when we go out in the field and we talk with patients in a myriad of different healthcare situations, what we hear over and over and over is, I don't want to be here, I want to go home, I want life to get back to normal, and any number of variants on that same opinion. So what's going on is we're asking someone to be the hero of our designed experience by casting them in a consumer light who actually probably has very little desire to really be participating in it. And that's a lot to ask of a reluctant hero. Second reason why we think patients and consumers are pretty different from each other is that they're not necessarily well equipped to be there. If we think about what we're demanding of patients in most healthcare situations, we're asking them to make really important decisions, okay, at a time of incredibly high stress, and to top it all off, they probably feel like crap as well. And now, not only that, but we're going to give them yet another job. We're going to ask them to be responsible for making sense of all of this additional information and to assume the role of the expert. But what we think is that domain expertise is actually still necessary when it comes to medicine. And finally, the third reason why we think that consumers and patients are pretty different from each other is that they're not acting alone. Now, we recognize that, of course, consumers have networks of influencers, but largely, people are encouraged to make consumption decisions independently and autonomously. But patients exist within an incredibly complex system. In fact, if we had drawn it true to life, we'd probably still be back in Boston drawing stick figures, because this only goes partway towards representing what I think we all know is an incredibly complicated landscape of patients, practitioners, insurers, administrators, hospitals and clinics, back-end systems, friends and family and loved ones, and so on and so forth. I mean, if you think about even just one example, let's take diabetes care. And you think about the number of stakeholders involved in even one medical encounter or office visit, how complicated it is. And that's not even considering the complexity of management of that condition over months or even years of a person's life. So as much as it might be appealing to think about patients as independent, autonomous actors, it's really about the system as well. And as we know, that system can get incredibly complex.
So we come to understand that asking patients to behave like consumers is not going to be the easy answer that we might hope it could be. But we also understand that asking the system to remain the same is untenable, and that leaving patients in this situation outside of the sphere of influence and information and control is not going to work. We understand that our system is in a place of massive change, and that we have to look at the role of the patient as undergoing change as well. So where does that leave us? Well, for starters, let's acknowledge that healthcare is not Amazon.com. Healthcare is not and should not be a consumer experience, and to treat it as one is a missed opportunity. And yet, we see our clients, we see our colleagues, we ourselves rely really heavily on the practices and methods of consumer-centric design. And we think that we can do one better. So we've been thinking about what might need to change as we continue to port consumer-centric practices into the healthcare space. For starters, I think we need to acknowledge that there's a major engagement gap, and Don talked a little bit about this. I think the folks here in this room, it's safe to say, are some of the most engaged, proactive thinkers about healthcare, maybe in our country. We're totally the health nerds. We're health teachers' pets. And it's either our job or our personal passion to sit around and talk about health a lot. Our health, other people's health, the future of health. Like, this is a really cool thing. Good for us. And no offense, guys, but we are kind of weird. Like, we're not normal. Normal people don't think about health all day. They think about their jobs or getting their kids back to school or the bills they need to pay. They think about that stuff that is the real meat of life. And time again, when we do our research with consumers, we find that health is like the tiniest sliver in the pie chart of their hearts and of their minds. And our real opportunity is not to try to grow that piece of pie, but in fact to sync up with the bigger pieces that already exist and to link into what's truly important to folks. So I think the reminder for us is that we're not the target, and we need to design not for the e-patient Daves, although it would be awesome if we had more of those, but for a patient who really is not engaged in their health. Second, I think we need to acknowledge that the stories that live in our heads are not the stories that live in our patients' heads, and that what we say, whether it's literally through words or through designed experiences, is not necessarily what they hear. I think oftentimes patient centricity makes these assumptions around shared narratives, shared values, shared goals, and I don't think it's safe to make those assumptions. There are a ton of like end-of-life stories, for example, that highlight what can happen when healthcare's values come in conflict with patient values. And I think what we need to do instead is design so that we can truly understand our patients' values, work together to build common goals, and then create that narrative in collaboration with them so that we are truly pointing in the same direction. And then finally, I'd like for just all of us to get over this notion of the ideal. I had a client not so long ago who we were working with in designing a system for folks who are managing diabetes. And we got into the conversation about what would success on this project look like. And I was totally shocked when the client said that for them, success was 100%. 100% engagement, 100% compliance, like 100%. And like, first of all, this is like a really great thing to tell your design team if you want to totally freak them out. But more importantly, it was just so deaf to the realities of the situation. And it was setting us all up for really unrealistic results. Either we were going to fail, or we were going to make such a inconsequential impact as to be meaningless. And I think it kind of makes sense when you think about it through the consumer lens, because oftentimes in consumer design, we do design for ideal scenarios. We design these scenarios in which the consumer leaves the store, product in hand and cash in the register, and like, the sun breaks through the clouds and the music plays and all is well with the world. And we have to put that aside when it comes to healthcare, because so often in healthcare there is no ideal. People are going to die. People are going to not do what we want them to do. And there are going to be times when what's right is in conflict with what's right for them. And we have to expect that patients are sometimes going to choose what works over what's best. And I think it's our responsibility here to design systems and to train our people so that that's expected, so that we're designing for that level of flexibility and we're creating a system in which failure is not always failure. So where we're at is not to get rid of the notion of patient centricity, but really to redefine what we mean when we say patient-centric. So it's not so much about being patient-centric as it is about being connection-centric, dialogue-centric, that we're building a system that's more fluent in each other's languages and that enables a more transparent, more honest understanding of the trade-offs that are implicit when we talk about healthcare. And I think I'm super excited to be sharing this with you all here today because I think we have a huge opportunity. And this is an opportunity not to follow, but to lead. not simply to wholesale adopt the consumer-centric practices that consumer companies have been building for years to their needs, but instead to say, we are not Procter & Gamble, we're not the Ritz-Carlton. This is our own special hairball of needs and opportunities and challenges, and we can shape practices specific to that. So what we've done today is shared some of our thoughts on what we think might need to be considered as we build those practices. But we really hope that you guys take it farther, and we hope that you'll let us know what you learn along the way. Thanks very much.
Thanks so much, guys.
Thank you.
I'm sure you're going to hear what people think.
We'll get an earful.
Absolutely.
So.
But seriously, the themes there, again, they are provocative and potentially contradictory to what's already